Hello everyone. Today I am coming up with a video of Thuflep, that is thulium fiber laser enucleation of prostate, an en bloc technique with a new development by us, that is unidirectional en bloc technique. There is multiple advantages when we do an en bloc enucleation over a bilobar or trilobar technique. Though for a beginner, to start with a trilobar technique is the easiest to perform and to maintain the tract, and it helps in maintaining the enucleation plan in a bigger gland or for a beginner. And once the experience increases, the surgeon can shift to bilobar technique and then to unilobar technique and block enucleation, which helps, like, we need not have to meet the enucleation plan at multiple sites as in case of bilobar or a trilobar technique, and it saves lots of time. And when there is even saving 1 minute time in an elderly gentleman helps in the morbidity and post-op recovery. While doing unidirectional en bloc technique, which we have developed recently at our Advanced Urology and Kidney Diseases Center at Guwahati, what we found out that by doing unidirectional, even we are not joining the en bloc resection plan, which starts initially at 5 o'clock position, and after the apical dissection, and then the lateral dissection, and at 12 o'clock. Again, we start on the 7 o'clock. Then there also we need to meet two enucleation plan either at 12 o'clock or maybe at 1 or 11 o'clock position. By doing this unidirectional technique, what we do, we start enucleation at 5 o'clock position, then gradually we enucleate the lobe, and at 12 o'clock position, after reaching 12 o'clock position, we do not end there, and we continue enucleating the gland with the same enucleation plan on the other side. As I am a right-handed surgeon, I always start in the left side, so it is 5 o'clock position. A person who is a left-handed, he may prefer to start at 7 o'clock position, and the things will be vice versa. And then what happens, the most advantageous point in this unidirectional technique is, while enucleating at 11 o'clock position to 9 o'clock position for a right-handed surgeon is the most difficult part because of the anti-clockwise extreme rotational movement which is required to reach out at that plane, and always there is a chance of going subtrigonal or the going deeper into the capsule. So by doing this, what happens, once we enucleate from the 11 o'clock to from the 12 o'clock to 11 or gradually to 10 o'clock position, the weight of the adenoma helps in finding out the enucleation plan, which otherwise we would have to lift up with the beak of the assembly of the resectoscope. Here, the adenoma weight of the adenoma, it helps in maintaining and finding the enucleation plan. So we have done nearly 50 cases with this new technique, and recently I have demonstrated this technique in a live operative workshop organized at Preeti Hospital, Hyderabad, and the holmium laser enucleation of prostate versus thulium laser enucleation of prostate, and the spectators and the doctors also found it easier and good technique to follow. Let's see the here. I am using a 60 watt thulium fiber laser from IPG, which we are using for nearly last 3 years or so, and we are very happy with the functioning with the machine. As you can see, I am initially putting the incision just proximal to verumontanum. Here I am using a coagulation mode of the laser, which is a low power mode, 0.1 joule, 300 hertz, and I use this energy setting near the verumontanum. And for the lateral marking incision, you can say it early mucosal release, and which helps in maintaining the distal limit of the enucleation while doing the en bloc unidirectional technique, and at the same time, early mucosal release, there are lots of studies and data that it prevents the stress urinary incontinence postoperatively. After the marking incision, now I am changing to the new energy setting, which we are doing for last 50 cases or so. It is a high power setting, and it is 4 joule 13.5 hertz energy, and it helps like splitting the tissue, as in case of holmium laser. As you can see, the charring effect is nearly nil, and I am away from the tissue. I'm not touching here the tissue. I'm keeping the tip of the fiber few millimeter away from the tissue, and at some places we can touch the tissue also, and it is very fast. And as you can see that by just stretching the adenoma without applying much of mechanical force, I am enucleating the tissue. And here you can see I did the enucleation at the apical tissue on the left side, and then gradually I am enucleating the adenoma in the lateral side, and I'm going towards the bladder neck. Here, what we do usually in our this en bloc unidirectional cases, that I enter the bladder near 3 o'clock position, and it has again several advantages by doing this, because the adenoma is quite straighter there, so we need not have to follow a much concave plan which we encounter at 6 o'clock position. And at 6 o'clock position, if we go to enter the tissue, enter the bladder, there are always chances of going subtrigonal and entering into the capsule. Here, as the adenoma is much straighter, and yes, you can see that I have entered the bladder at 3 o'clock position, and there are not even minimal chance of injuring the ureteric orifice, which otherwise the case in case of entering the bladder in 6 o'clock position, and we have to be cautious and seeing the blood ureteric orifice all the time. But here, as we are coming from lateral to medial, there are no chance, and if we maintain the enucleation plan just near the adenoma, so there are no chances of going subtrigonal and towards the ureteric orifice. Here, as I have already explained, that after going to 12 o'clock position, we continue enucleating the lobe in the other side, and as you can see that I have nearly reached 10 o'clock position, and now you can feel that the weight of the adenoma when it falls off, and it helps in finding out the enucleation plan, and which we need not have to follow from the other side, like again coming from the 7 o'clock position. Here you can see that the bladder neck also, as we are coming from the bladder neck which we have entered at 3 o'clock position, we need not have to enter at multiple sites, as we would have to enter the bladder again while doing enucleation even en bloc from the other side, like 7 o'clock position in the conventional technique. Here we are just coming along the bladder neck, and you can see the ureteric orifice so well visible. Here you can see that going from the adenoma towards ureteric orifice or towards the trigon, what we are doing, we are initially marking the just distal to the trigon, and that will be the proximal ligament. So there are no chance of even going subtrigonal, no chance of injuring to the ureteric orifices. Here you can see that we have nearly completed the enucleation, and at one shot or at one go from the 5 o'clock position, being a right-handed surgeon, which I prefer to start at 5 o'clock position in the left side, that for a left-handed surgeon it can be just vice versa, you can start at 7 o'clock position. Now you can see that through the same plan we nearly completed the enucleation. Is the 60-gram gland. You can see that with this new energy setting, with this new unidirectional technique, we can complete this technique in no time. It saves lots of time, and with this new technique, with the new energy setting, we can completely enucleate. As you can see that even the prostatic urethra is so well visible, and this is a complete enucleation. You can see with the hemostatic setting of of 30 watt energy, 0.1 joule, 300 hertz. Very easily we can do pinpoint coagulation of the bleeding point, which we should do with a round after complete enucleating it, after we send the assembly to the marcellation technique. We need to do ensure complete hemostasis so that the marcellation can be straightforward. Here we are using a two-head rotating kind of marcellator for our last nearly 200 cases, and we are very happy with the function of this marcellator. Thank you.